doing my ACIs or a gel-based cartilage regeneration technique. I won't call it a transplant because this is not exactly a transplant there. So just show you a couple of places. The concept of regeneration has been there in our evolution since I think millions of years. So if you have read your biology, you know the planaria, the hydra and starfish, if you cut a stem, cut the limbs, they will all regenerate back. Even a lizard's tail regenerates back. So this is where the concept started from, and there's a different branches coming up of regenerative medicine where we are able to regenerate a lot of tissues in the laboratory there. And cartilage regeneration has been going on since the 1980s. The documented surgical procedures have been there, and we are kind of getting better. The problem with cartilage is that somehow it doesn't have the blood cells there. The nourishment comes through diffusion, effusion, and mostly an adult cartilage does not kind of regenerate there. So the problem with loss of cartilage is that it exposes the underlying bones, and that's where it becomes painful because of the exposed nerve endings. The scenarios which we get to see is trauma mostly, and osteochondritis dissecans, infections, osteoarthritis, and inflammatory disorders. As you see in rheumatoid arthritis, regeneration of cartilage once is lost is kind of negligible. Osteoarthritis comes second poor there. Infections, of course, treated well, the cartilage can regenerate. In osteochondritis dissecans, regeneration potential is not 100% because it's an avascular event. In trauma, because there are fresh cases, especially young patients, these have a chance of regeneration there. I'm going to focus mostly on traumatic cartilage loss and osteochondritis dissecans and some idiopathic varieties which we have encountered in our scenario there. Now, there are various treatment options. If you have a very young patient, let's say who the physis is open and you have a cartilage lesion there, if you must have seen these osteochondritis dissecans or other idiopathic cartilage loss, they heal. They heal because they have a regeneration potential. The other thing is to do an arthroscopic debridement where you just remove it. You can do microfracture after that. You can do oats, or later on in your life, the only options left is unicondylar knee replacement there. What happens if you don't treat this cartilage? We all know it goes into progression of osteoarthritis. The average years it takes for a grade 4 cartilage thickness to change into a full thickness osteoarthritis, full grade 4 arthritis is around 5 to 6 years. So by that time they will kind of limp. So if you have a 30-year-old with a cartilage loss of let's say 2 square centimeters, maybe you can be rest assured in a couple of 5-6 years he'll have arthritis there. The procedure is kind of simple. Ritik talked about it, and we just take a small biopsy piece of cartilage. It is sent to a GMP certified lab in a special solute, and it cultures cartilage cells there. It's a cells. They are not stem cells, they are just cells of cartilage, which will have a delivery agent as in the form of fibrin, and that will go and stick to the area where it will finally regenerate into new cartilage there. The cartilage cells will not immediately form cartilage. It takes time. It takes around 6 weeks to 12 weeks for the cartilage to form. So this is a compilation of all the cases, and I have to thank many of my colleagues who have kind of presented, contributed to these cases there. So over the years, I think 2015 we got the kind of DGCI approval for that. So these are 22 cases. Mostly they were femoral condyle cases. We had some patellar lesions, talus lesions, humeral defects, and most of them were idiopathic. And the second common was osteochondritis dissecans, and 4 cases of traumatic injuries were there. So this was my first case. I always show this. He is a doctor. I had a hard time convincing him because he was my first case. He's a medical, he's an MD doctor there, and you can see. He was around, I think, 35 years then, and this is the large defect he had, and there are not many options during that time, and I spoke to the lab and they said we'll supply with the tools there. So the first thing is to take this punch biopsy. This is a very simple procedure. The first stage, it's in a daycare procedure. You do an arthroscopy, take this small punch from the non-weight bearing area, and this is the key. I found this is the most difficult part, trying to take out the small piece of cartilage with the piece of bone. You have to be very careful that you do not damage that bone which is attached to the cartilage, because cartilage will otherwise not survive. It requires a piece of bone fixed to that area. You can see that thing gently coming out there. And once you have this thing, you kind of transfer into this medium. It is supplied by the company itself. and you put it there and you send it across to the laboratory in Pune. And after 4 weeks, that is the time, they'll tell you that the cartilage has been cultured. Now, in few cases, they actually are not able to culture cartilage. So that's a dead end for the patient. And so you need to tell them that, in case your cartilage is not cultured, then we won't be able to do the second procedure. But this is an open procedure. In certain cases, you can do a dry arthroscopy and do it. You actually create a nice crater. You create the bone there. It has to be absolutely dry. And you make small holes into that bone, and again try to make it dry, and then you mix with fibrin and inject into that area. Initially it will look very flimsy, but after a couple of minutes you will see it solidifying, but again it will be like gel, and it will not be white in color. And once you are done, you kind of move the knee up and down there, and it forms into the it will take the shape of the bone there, and you just close that knee there. Initially it's non-weight bearing for 2 weeks, and 2 to 4 weeks you start exercising, and active sports can be done at 8 to 12 weeks there. So this was the MRI at 12 months of the doctor there. You can see the difference there. And these are certain cases. This was a traumatic case, 25 years old. Some of the patients actually consented for a relook because it was new. We told them that we don't know what's going on. They actually consented for a relook. Some actually had minor stiffness. We had to do a small release there inside. This is another case, idiopathic variety, 30 years old male. You can see the 8. So we can do up to 15 or 18 square centimeter defect, large defects. Even multiple defects can be done. This is a traumatic case. You can see the bone absolutely fresh there. So overall we had very good results. We had very good results so far, and it has been seen that the initial 4 years or so, the results are fantastic. They deteriorate a bit after that, but still I would say around 70 to 80% of the cases will have fresh good cartilage. These are not fibrocartilage, these are hyaline cartilage there. And this is one case of one of the shoulders I did. You can see the lines defect there and the cartilage forming fully grown there. This was an open procedure. This was not a arthroscopic procedure there. The cost is prohibitive. In India, in our hospital, probably cost you around 3.5 lakhs. Works very good in younger patients. And the cartilage was biopsied after it regrew. It was almost like hyaline cartilage. Very few fibrocartilage was seen there, and this is the only way you can prevent actually your further cartilage loss and preventing osteoarthritis in the future there. And also it can be used in multiple lesions. My personal experience says that in osteoarthritis it doesn't work well. So be careful. If the patient has osteoarthritis, don't do it. But if it is an isolated loss in a patient with osteoarthritis, then you can probably do this technique there. Thank you.